morning, Madam Chair and members of the committee. I'm here on behalf of the Michigan section of the American Congress of Obstetricians and Gynecologists. I am a practicing obstetrician and gynecologist in Canton, Michigan, and every day I am at the forefront of treating sexually transmitted infections, educating patients about prevention of sexually transmitted infections and prevention of reinfection of this disease. I have seen the benefits to treatment of both patients and their sexual partners, and I have seen the adverse outcomes that can occur if they are left untreated. Not only adverse outcomes to our patients, but to their unborn babies. As so well outlined in the previous testimony, expedited partner therapy allows us to prevent the spread of sexually transmitted infection. And by doing so, we engage in this treatment through a patient-delivered partner therapy without the partner receiving a medical evaluation. Obviously, there is some burden to our index patient to contact all of their sexual partners. They are advised to do so, and that is the current standard of care in medical practices. As women's healthcare physicians, we are at the forefront of treating these diseases. Gonorrhea and chlamydia are the most commonly reported sexually transmitted infections in women ages 15 to 24. And as mentioned in previous testimony, consequences to untreated disease include chronic pelvic pain, infertility, as well as complications to the unborn children. We've seen an increased risk of preterm birth in women who do not have these sexually transmitted infections treated during their pregnancies. And we also have seen risks to the newborns, including blindness. Here in Michigan, we have seen the incidence since 2007 of chlamydia increase, actually tripling. And currently, the U.S. Preventative Task Force recommends that all women ages under the age of 24 have screening annually. It is a grade A recommendation. And if we don't have the opportunity to treat these patients and then their partners, we're going to return to higher rates of reinfection. In fact, if partners are not treated, the reinfection rate may be as high as 25 to 30%. So we, as mentioned, have tools in our toolkit to look at managing sexually transmitted infections. There, first and foremost, is the education piece and the prevention piece, and that's what healthcare providers and ACOG is so intent on pursuing. But once that diagnosis is made, we need to have the tools to not only treat our index patients, but to prevent further harm to them with reinfection. So by allowing EPT legislation to pass in our state, we are going to be able to overwhelmingly improve the health care for women in the state of Michigan. As Dr. Mercant alluded to, the burden of the public health departments to notify providers, patients, and track sexually transmitted infections is overwhelming. And by allowing the healthcare providers to be at the front line of managing their treatment, we are going to expedite, speed up how quickly this index patient is treated and prevent the index patient from reinfection much more quickly than if we have to rely on the public health departments, which are already overwhelmed and burdened. The only obstacle left is the legal obstacle. So when I return to my practice today in Canton, Michigan, I hope that not only will I be able to talk to patients about prevention of sexually transmitted infections, treatment if that occurs, and how to contact their partners, I would like to be able to have the additional tool to provide expedited partner therapy. I thank you for your time this morning, and I would be happy to entertain any questions. Thank you.